All right, welcome. My name is Kyle Magatelli. I am the webinar and social media coordinator for Student Doctor Network, and very happy to have you guys here with us as we are joined by Dr. Christopher Choukalas, an academic anesthesiologist and intensive care physician for our academic anesthesia and intensive care physician webinar. Dr. Choukalas, thank you for taking time out of your day to join us.
Terrific, glad to be here.
Perfect. So before we kick it off with the questions, I want to tell you guys a little bit about Student Doctor. So Student Doctor Network, we're best known for our forums. We have a bevy of resources, though. I always say it's a lot better to go onto studentdoctor.net and poke around versus me just telling you stuff. And the crux of what we do, we believe every student should have the same opportunity to attend a health professional school. We're focused on providing free resources so that you can get from your pre-health student journey, you can get from that part of the journey to becoming an attending. So our community, the forums, we have, oh gosh, there's a lot of users. There's a lot. I can't remember the exact number, and I usually underestimate by a few 100,000. Hop on there. Whatever type of medicine you are interested in, there's a subspecialty forum. You can learn from people that do this work day in and out. Confidential expert advice is a personal favorite of mine. If you are a pre-health student and you need a no-nonsense answer, hop onto the confidential expert advice. You will find out what you need to know. My experience has been, I don't always like the answer, but it's been exactly what I need to hear to be able to set myself up best for success. Pre-Med Planner app, this takes you from day one of stepping on campus to when you're putting in your applications. Something that's really great about this is tracking your hours. If you're doing clinicals and you do not track your hours, that is bad. So hop on there, get that. And you can find us on social media, all the usual suspects. You can find out what we're doing, find out more about webinars like these. We post resources, information regarding medicine, developments in the field, news, a little bit of everything and anything. So that is, again, just go on to studentdoctor.net. I've talked enough. So that part out of the way, Dr. Choukalas, if you could tell us a little bit about yourself, that would be awesome.
Sure, you bet. Thanks, Kyle. Well, my name's Chris Choukalas, and I am an anesthesiologist and intensive care physician. And I am at the University of California, San Francisco, and spend most of my time at the San Francisco VA Medical Center. I do a whole range of anesthesia cases. I take care of intensive care patients in a medical ICU, in a surgical ICU, and in a neurosurgical ICU. So my practice is very broad. I have no 2 days that are the same, which I'm looking forward to telling you guys all about. And I am recently, well, almost 2 years now, a new parent at the ripe old age of now 47. So I've got two toddler girls at home, which makes work in some ways a lot easier, actually. And I think parents of young children know exactly what I'm talking about. So that's what I do. My hobbies, as with most people in medicine, are few and have only gotten fewer during the pandemic and fatherhood, but still try to get out on the road bike and some of these beautiful roads and hills and mountains in the Bay Area, and mostly just spending time outside as much as possible. So that's me in a nutshell.
That is a pretty prime area for that. I do want to double back. Hey, everybody, I messed up pronouncing your name.
You are not the first and will not be the last.
I actually have it written down on a pad here, and I still somehow got it wrong. So Choukalas.
Call like on the phone.
I'm just going to give up if that's acceptable.
I'm just going to say, I'll just say it myself as many times as I can.
I apologize.
No sweat.
So for everybody viewing this, I've had about 8 or 9 attempts to get this right, and we're still getting it wrong. So first question, how and why did you choose the medical school you attended?
Sure. So I attended the University of Minnesota Medical School, which was my home state institution. And I applied broadly and I interviewed broadly and I was accepted and waitlisted somewhat less broadly, but still broadly. And ultimately, it was kind of a checkbox decision for me in the sense that, you ask these places like, well, what am I going to get if I spend more money coming to you as opposed to my state school? Like, are your residency math statistics any better? Is there something about the curriculum that's going to be better? Are my prospects going to be better? Am I going to make more money or match in a better specialty? And it was really difficult for anybody to answer that question with any kind of clarity. And so when faced with the huge difference in tuition, it was an easy decision for me. Now, it just so happens that the University of Minnesota is an excellent medical school, so it was not a hard decision to make. But really, it came down to tuition and just the sense that my prospects there would be just as good as any other more expensive place that I could have chosen. I think too, all the other places were out of state, and I'd never really lived out of state before, at least not that far away. And I think being close to family and friends was going to be important for me. And it was, because I was broke through school and I had friends to buy me beer and pizza. So it worked out to my advantage.
That's always a good thing to have at any stage in life.
Absolutely.
Okay, awesome. So next question, why did you decide to pursue your specialty?
This was a very difficult and very personal decision process for me. I didn't have any physicians in my family. I'm the first. And other than seeing my primary care doctor as a teenager, I didn't really have any memories of what a doctor did. But when I started my clinical rotations, I was impressed by a couple of things. First, that so many of the rotations had as my job to write a bunch of stuff down on paper for people to do to the patient, and then to come around the next day and figure out why half of the things didn't get done. And the actual work was so far removed from the patient itself. And by the way, something that's only gotten worse with the advent of the computerized medical record. It just felt so removed from actually touching the patient that it felt kind of boring, and also it didn't really feel like doing medicine. The other thing that impressed me is that I did neurosurgery as an early rotation, and I think what I encountered was that people doing surgery were pretty miserable and unhappy and not very nice to be around. So what did that leave me with? I wanted to be in a specialty where you are actually touching people and doing stuff to them in a direct way, but that cutting into people made you a jerk. At least that's how it looked at the time. So once I started doing my anesthesia rotations, it just felt, ironically, more like what I thought being a doctor was, where you're actually kind of there with your patient, you're doing stuff, and something happens and you do something different. And that just felt like what I imagined doctoring to be, but in a more immediate way. I still did pursue surgery in the form of ENT residency, actually. And my grandfather, who served in World War II, it turned out had been a medic for an ENT surgeon in the war. And around the time that I was having to make decisions about matching, he died. And I learned all these things about him basically at his wake the day before the ENT early match forms were due. So suffice it to say, I spent a lot of time and stress thinking about, well, is this a sign? Should I be trying to match an ENT after all? And in the end, I didn't, and I withdrew, and I went straight for the regular match for anesthesia, and have been very happy that I did.
Awesome. So how did you become involved in intensive care? And can you please tell us a little bit about the training and role of an intensive care physician for anyone who may not be familiar? And by anyone, I mean me, because I don't know anything about it.
Yeah, absolutely. So intensive care is really the care of patients that are too sick to be anywhere in the hospital other than the intensive care unit. So traditionally, you might think of that as like patients on life support. So who's on the ventilator, who's on life support drugs, who has maybe had cardiac arrest, who might be on mechanical device support, who might have injuries so severe that they have equipment in them that can only safely be used in an intensive care unit. And I got interested in that in part directly through work in anesthesia. On the mechanical side, so sort of like running and managing the life support, organ support kinds of things, that's a very natural extension of what an anesthesiologist does in the operating room. The techniques are similar, the medications are similar, the goals are similar. And but then from sort of a medical diagnostic standpoint is really different from what we typically do. So that while there are a lot of pathways to train to become board certified in intensive care medicine, each of those fellowship paths might look a little different. So for example, if you're an internal medicine person wanting to be an intensive care doctor, you would do a fellowship in pulmonary medicine and critical care, and you'll focus a lot of time on perhaps the more mechanical and management aspects of the care. As an anesthesiologist, your fellowship might focus a little bit more on the medical diagnostic side, since those are the things that you wouldn't have necessarily had in your residency. But now, neurologists can become intensive care physicians, emergency medicine physicians can become intensive care physicians. So for me, for an anesthesiologist, it was a 1-year fellowship. For an internal medicine person, because it's combined with pulmonary medicine, it's usually 3 years of fellowship. Emergency medicine is usually 2, and so it really varies from in terms of which specialty you come from. And I would add to that too that surgeons train to be intensivists, usually combined with trauma surgery, and that's a 2-year fellowship.
Wow. So with the time involved, it sounds like you'd have to have a real passion for that kind of work.
Definitely, it's as an anesthesiologist, you're doing I suppose you could say it's one of the shorter pathways in the sense that your residency is 4 years and it's a 1-year fellowship. When I have trainees come to me and say, I'm thinking about doing fellowship X, I always run down the numbers for them because, a year of lost income invested, over the course of your career comes to a very large number. And so you really want to be sure that you want to take that extra year to get that extra training because it's costing you a lot of money over the course of your career to spend 1 more year out of the workforce. Intensive care is one of those things that you really can't do without the fellowship. So in a way, it's kind of a moot point. But yes, you do have to want it because it's more time. And then when you're working, it's often more weekends, more nights than what your non-ICU anesthesiologist colleagues are likely doing.
Okay. Thank you for expanding upon that.
Sure.
So how'd you become involved in academia with anesthesiology rather than just being solely focused on practice?
It never, to me, being an academic physician is as different from being a private practice physician as being a cop versus a fireman. They're vaguely both in the public safety sphere, but the jobs are totally different. And to be honest, it never really occurred to me to go out into practice. I was always interested in being part of a large group, academic inquiry focused group, being at a big place that did lots of complicated things on sick people. Like that's just what I liked. I learned early on, even before medical school, that a big part of my identity was, I don't want to say academic prestige, but there's something about being part of a large, thriving university setting that's very satisfying and very fun and very interesting. And so to me, that was plan A from the very beginning. And I never really saw myself in any other light. Now, having said that, I've been out 12 years. I got loans to pay. I've now got 2 toddlers, which I keep referring to. And the cliche is true. Once you have kids, everything changes. And I have had to start re-examining that decision because I work a lot of hours. I'm paid well, but not as well as out in some private practices. And so I've had to at least consider whether I could be happy in a setting other than the one that I'm in.
Okay.
As we age, our priorities change.
Yeah, I'm finding that one out myself. Not enjoying it, but finding it out.
Fair enough.
Okay. I didn't include this, but just to dovetail a little bit, can you tell us about what piece of published work are you most proud of or has been the most interesting for you to have been involved in?
Well, so that's a really funny question because so a few years ago, well, I mean, people probably haven't read my CV, but before going to medical school, I was in a doctoral program in counseling psychology. And I left after the master's degree to do my pre-med, so I didn't finish the PhD. But I published a few things along the way. And one of them was a statistical manual for how to make SPSS, which is a statistical programming language, how to make it do a particular thing that facilitated the analysis of these large data sets for this research institute on like family dynamics I was part of this research institute as a graduate student, and they did work on family communication episodes, and people would videotape families having discussions about things, and then experts would rate them for certain behaviors, and then I would analyze the data. And so I wrote the statistical manual to make a program do a thing. So pretty dry, really technical, really boring. And if you ask me how to do it today, I would probably have a stroke. But when I Googled myself partway through my academic career, I'd published a bunch of other stuff. I mean, I'm a co-author of Miller's Anesthesia. I have published a handful of things on COVID and on resource utilization and delirium. But I tell you, the thing that gets more hits and more citations by far is this quirky, wonky statistical manual that I published in Ames, Iowa, like 25 years ago that I haven't thought about since. So is it the thing I'm most proud of? I don't know, but it's certainly the thing that has generated the most interest since being published.
Okay, interesting. I'm
You
probably going to
simply
Google that.
you simply can't know what people are going to respond to. It's really true.
I mean, I've had to do data analysis, and it's terrible. Any tool that you can get to help make it a little easier, especially if someone else suffered, so you don't have to. Oh, yeah.
I suffered greatly.
All right, awesome. Okay. Next question. What does a typical day look like for you?
People are fond of saying there's no typical day, and that kind of is true. Each week for me is a little different in the sense that some weeks I'm in the intensive care unit and some weeks I'm in the OR. The weeks that I'm in the intensive care unit, some of those weeks are at the VA and some of those weeks are at the university. So the VA weeks I drive to work, the university weeks I walk to work. So just even the beginning of the day is just totally different. Obviously an ICU week, I go to my office, I will look up the patients, try to do, frankly, a little pre-running on myself, because you always wonder like why your attending seems to know more than you do, even though you've spent all this time, pre-running on the patients, because we get there first. There's no work hour limitations for your boss, but I try to look up the difficult patients, the complicated people, review whether anything's happened overnight. There's an ever-growing list of huddles to attend, and then we talk about patients as a group. We go around, look at everybody, touch everybody, look at the labs, look at the x-rays, talk about what we think the diagnosis is, what we want to do. And then I write a bunch of notes because notes are how the hospital gets paid. And then I teach. I go around with the medical students, I go around with the interns and residents, and we do some kind of teaching rounds. And sometimes that'll be having them touch every bit of plastic in the room and see where it touches the patient, where it touches the machines, and what it actually does. Sometimes we'll do ultrasound rounds where we'll go and look at people's hearts and lungs and other body parts on ultrasound, see if there's inferences we can make about their physiology. And sometimes it'll just be a question and answer session about like what we did today, why we made the decisions that we made. And that's that day. The operating room, totally different. I come to work, I get to my office, I look up the patient. So that sounds the same, but then I go and see people, and sometimes I'm working by myself, sometimes I'm supervising residents, and sometimes I'm supervising nurse anesthetists. So which of those I'm doing will determine kind of what my day looks like. Obviously with the residents, I'm doing a lot of teaching. And I'm sort of patiently watching them try things, generally with a high degree of success. But we at the VA get residents in their very first year, and so they tend to be less experienced. So that means I get to do more. With the nurse anesthetists, we have a really capable, experienced group here, so I'm usually doing less, but they're often curious about decision making as well. So those are usually thoughtful and interesting discussions with them about sort of how we're going to tackle a problem. Community relations with surgeons about why this is happening or that's happening. And I basically spend the whole day either talking to patients, working on patients, or communicating with other people about those patients.
So it sounds like you're just really busy all the time.
It's pretty busy, and once they're out of the operating room, it's not really over. So we're managing them in the recovery room. We're often helping to manage that transition to the intensive care unit for those patients going there. And, because we are interested and because we care and because the patient deserves it, we often stay involved, for hours and sometimes days afterwards when there are issues, either with maybe they've got an epidural in that needs to be managed, or maybe they remained on the ventilator due to some complication, and we're working with the intensive care team on what happened and why and where to go next. So there is some continuity even in this field.
Okay, excellent.
I want to just say one other thing, because we don't usually think of anesthesiologists as having continuity of care, but the other night on call, I actually had a patient come in for an emergency upper endoscopy for a GI bleed, and everybody was saying, oh, this patient has a history of difficult airway. They had some failed intubation attempt years and years ago, and somebody had to come into the room and do a slash cricothyrotomy on the patient, basically a neck incision and then a breathing tube inserted through the neck. And gosh, isn't that terrible? What are we going to do? And I'm thinking to myself, I'm pretty sure that was me. And I looked at this guy's record, and sure enough, I had criked this guy back in 2011. And here he is coming in now with this history of difficult intubation for an emergency procedure, and I happen to be on call. So even in anesthesia, you can get very interesting continuity of care.
Pretty low odds on that one. That's interesting.
You'll do your whole career and not have that happen. But I was in the right place at the right time, or maybe the wrong place at the wrong time, depending upon how you look at it.
Yeah. Okay, awesome. So next question, this is a good one. What are your thoughts regarding states opting out of federal regulations requiring physician supervision of certified registered nurse anesthesiologists? I'm giving up on words today.
Yeah. Anesthetist, yeah.
I can't get your name right. I can't get this right. We're done.
Yeah, right. We'll quit. This is a highly charged topic, and one that gets a lot of attention, all up and down the spectrum of policy, politics, and training. Residents and students want to know, like, am I going to have a job? What about all these opt-out states? Are our quote-unquote mid-levels sort of taking over the specialty? And I guess what I would say to that is in part an answer and in part a dodge. I think the first thing we all need to acknowledge is there simply aren't enough anesthesiologists to do every case that needs to be done. The requirement for anesthesia services is simply too high and is growing every year. There's always some new thing somebody wants to do that requires a patient have a capable human, not just to keep them asleep, but to keep them safe. And there just aren't enough doctors to do it. So if you're going to have somebody other than a doctor doing it, what do you want that system to look like? And I think that the anesthesia care team, where a doctor is medically directing a small number of highly trained advanced practice nurses, is a very good and safe model. What you see in these opt-out provisions is simply a way that states are responding to political pressure to expand and make less expensive the provision of services. This is largely a political ploy because these opt-out provisions simply remove the requirement of physician medical direction for the purposes of billing Medicare. They don't mean that nurse anesthetists can automatically practice independently in those states. Scope of practice is state level, yes, but even more micro at hospital level. So firstly, most patients that you're taking care of are not Medicare patients. So this provision applies only to Medicare patients. Secondly, hospital bylaws almost exclusively continue to require physician oversight in one form or another, and that oversight can take different forms. But medical direction of a small number of nurse anesthetists is by far the most prevalent model. And that's baked into hospital bylaws. So I guess I would say that whether or not you agree that nurse anesthetists should be able to bill Medicare on their own or not is a very different question than, are these advanced practice nurses allowed to practice independently? And for the most part, they're not practicing independently. For the most part, they don't want to practice independently, has been my observation. And I actually think that either person, either physician or CRNA practicing alone is probably less safe than the two of them practicing together in some sort of ratio of direction.
It's interesting. I recently read an article on this, and I don't recall having seen anything about Medicare in there. It was yeah.
These are CMS laws by and large. And the thing that also needs to be acknowledged here, and I don't want this to come across as a little bit of a dig, but people make it out that, and this isn't CRNA versus anesthesiologists, but advanced practice nurses in general, they bill the same code to your Blue Cross or Medicare that I bill. So the idea that they're somehow costing the system less isn't correct. They are paid less salary in part because they work fewer hours. There are unions and shifts and rules and laws about how many hours they are willing to work. And so if it's convenient to say that they are a less expensive alternative in a system that is getting more and more expensive, and therefore we should allow them to do more doctorly things. But at a granular level of what their services actually cost your health insurance provider, it is not different than what I'm charging.
That's interesting. It sounds wow. So everything just comes back to money at the end of the day. It sounds like
everything comes back to money and power.
Okay, well that's a whole different thread that we're not going to pull any further on.
That's a different AMA.
Okay, so this one, I'm a military veteran, so I'm pretty interested in this. Part of your work is at the San Francisco VA. How did that come about, and what do you like and dislike about it?
Well, I want to talk about that. I want to step back very quickly to the last question and just point out that what I hope came across in that discussion is that I actually think working together is safer than the other models that exist. And I feel that way honestly and earnestly because the nurse anesthetists and the ICU nurse practitioners with whom I've worked have been almost 100% very motivated, very capable, and very competent. And I wish that there was a way to look past some of the rhetoric on both sides so that we all could, it would all be a pretty good gig if we all just kind of kept doing what we did and took care of the patient. And I think the efforts to expand this or limit that are mostly just a waste of time, that we could be continuing to do research on policy and technologies to just make our work safer and easier. But with regard to the VA work, I never set foot in a VA before working in one, other than to interview here. So this came totally by surprise for me. When it was time to finish my fellowship and join the faculty, the university's ICUs were pretty full. They didn't have a lot of weeks available for me. And the VA was hiring somebody here, and they needed someone that could do a lot of ICU weeks. So I kind of looked at it. At the time, other hospitals weren't really using electronic medical records, and my data analysis interest was in large data sets, trying to analyze them to predict bad outcomes. And the VA was really the only game in town that had that. So it was this nice synergy of wanting more ICU time and also being a great place to do research. I got here and I the pay was a little lower than other jobs I could have had, but the workload was also a little bit lower. I found it to be a very functional, friendly, collegial place to work. In part, all the faculty here are UC faculty. Most were UC trainees. So we had, pretty high quality colleagues here. And a reasonable workload and work-life balance. And you'll hear a lot about the VA in terms of, is the quality of care good? Are people dying, because there's not enough care? And I think those are mostly overblown stories with political motivations. I think it's really difficult to look at a VA wait list out of context and say, well, this is too long for somebody to wait. But because the VA is the only shop in town that contractually has to publish their wait times, you don't actually know if those are any better than in the community. An example that I'll give is a part of an improvement project that I was involved in to try to reduce wait times for veterans seeking dermatology care. And the goal was to make it easier for veterans to seek care outside of the VA. And so we're in a room full of high-level physicians and executives, all of whom have private insurance that's well paid, kind of looking at each other, scratching our heads and saying, well, how are we going to get dermatology wait times below 31 days when it takes me 6 months with private insurance to see a dermatologist? So that was just one example that clued me into the fact that a lot of the things you hear about the VA aren't necessarily reflective of what's actually happening on the ground, but that are based on political motivations to make a soundbite for somebody trying to get elected. I have found this to be a very functional, compassionate system where my ability to take good care of patients has never been hindered.
Yeah, that's been my experience a couple of times I've needed care. It's, I got an MRI within like 3 weeks and I didn't have to pay for it. I mean, that's not an endorsement for running out and joining the military, but I just want to say, as military members, before we get out, we hear horror stories about, oh, the VA, like poor care, blah, blah, blah. A lot of that is people, there's a motivation to keep you in the service. So you hear all kinds of horror stories about how, you're going to the VA, you're going to be unemployed, et cetera, et cetera. So that hasn't been my experience at all. The VA has been, I'm in the Los Angeles system. It's like you said, it's, functional, streamlined. The physicians have been very focused on providing quality care. There's been follow-up and continuity. It's been a pretty positive experience. So I'm glad to hear that that's what you guys are delivering up there as well.
Well, and I have to say too, for your audience here, they're mostly people that are going to become physicians. And so they might think, well, is the VA a good place to work? And I got to tell you, there have been exceptions to this month over month, year over year, but for the most part, the work-life balance is pretty fair. Like, in other words, as I've said a couple of times, there are jobs I could take tomorrow that would pay me quite a bit more money. But what I've learned through the process of looking at some of those jobs is that I will work more for that money. That when I really look at what I'm being paid and what I'm being asked to do, most of the time it is a very fair package. The benefits are terrific. I get plenty of vacation. The retirement has changed over time. And so while I still get a pretty good 401k match and I don't have to contribute much to the pension, I think that as people have joined later, I think that those things are slightly less generous, but still very good. And when I look at like what I'm going to have in retirement, if I stay for 25 years or however many years, it's very, very good. Am I getting rich? I'm not. But it's enough. And I have enough. My job is not so intense most of the time that I'm stressed out or, can't go home to see my family or take the trips that I want to take. Honestly, it's a pretty fair gig. And I think that people should really look at the VA, and this isn't a plug. I don't care if you come work for me or not. My course is set here, but having looked around, I'm surprised at how fair and how good the package actually is.
Yeah, that's a lot of people don't think about how much vacation time you get with the federal government. It's more than you expect. It's very fair.
Well, I'll tell you, I get 6 weeks, plus there's 3 weeks of sick time, plus you get 12 weeks paid full leave when you have a kid. Now, my kids were born 1 month before that went into effect, so I did not get that, but I had saved up about 5 months of sick time. So I had 5 months of paternity leave when my twins were born. Drove my wife up the wall having me home that much, but I had it.
That's more vacation time than you get in the military. Also in the military, fun fact, kids, you don't get sick time. They just pump you cold. They give you a cold pack and tell you to get back to it. You got to be pretty messed up to get time off for being sick.
Well, you don't get sick time in private practice either. You're not working. You're not paid. Because if you're not submitting a bill, you're not getting paid.
That's interesting. I'm glad you expanded upon that because the VA is something I've thought about. Working with veterans is something that's close to me, and I didn't know all that about the compensation package. I mean, that vacation and sick time alone is massive.
Well, and I never have to think about a bill. I never have to think about whether the patient is insured. I never have to think about, well, this guy has Blue Cross and that guy has Medi-Cal. What am I going to do first? It's for somebody that's not a business person, that's not primarily motivated by eking out every possible dollar. I have to tell you, I sleep really well at night knowing that the care that I provide and the way that I think about my patients is never impacted by how much we're going to get paid for doing the things that we're doing to them.
Yeah, wow, that's awesome. Thank you for giving us a detailed answer about that.
Absolutely.
So, next question here, getting close to the end of our list. If you had to do it all over again, would you still choose your specialty? Why or why not? Do you ever stay up at night wondering, should I have gone ENT? Or tell us a little bit about that.
I did for a while think about whether I had made the right choice. I think when you go through internship, you are working in a team. You're kind of treated like a doctor. You have a little bit of control over your own time. If you need to stop doing your pre-rounds to go to the bathroom and to get a coffee, like, you can do that. And when you finish intern year, you're the best intern you're ever going to be. And then you start all over as an anesthesia resident. And instead of thinking and writing, you're kind of thinking and doing. So you're really bad at everything. All the people that you met and worked with as interns are all gone. So you're working with a whole new crop of people doing really badly at things that you don't know how to do. And for me, that loneliness was very difficult and very stressful. And it really made me second guess my decision. And until I was in about a year, when you start to feel a lot more confident in what you're doing, there were times where I thought I might have made the wrong choice. I think, like everybody says, eventually residency ends and it gets a lot better, and it did. And I think the way that I feel about being a physician now as an attending is really different than how I felt about being a physician as a resident. And I think as a resident, you're looked down on anyway. And I think as an anesthesia resident, you're surrounded by surgery residents most of the time who, look down on everybody. And so it was really hard to have confidence in what you've chosen. And there's such an artificial hierarchy in medicine about if you chose this or chose that, what does that say about who you are, how smart you are, what kind of person you are. And I think outside of academia and outside of the training paradigm, a lot of that disappears. And so it's been a lot easier as a faculty member and as an attending to be more confident and more proud of what I chose and what I do. And then I would add too, those lifestyle factors were really important. I know that if I were running a surgical practice and paying a staff and running an office and drumming up business, trying to keep the lights on, I think that I would be really stressed out by that. I think knowing that, patients were dependent upon me, even when I'm not there, that's hard and that's stressful for me. And so I think for me, the balance came out in the right place, and that knowing where I am now, I would go back and choose the same specialty, but it took a little while to get there.
Okay, awesome. Thank you. So last question we've got, and we know this is no longer a rumor. You confirmed
Yeah.
it. You've got twin toddlers at home. How do you balance your family life against a demanding profession? We know that you already drove your wife up the wall with all that time off. We got that part out of the way. What now?
Yeah, well, I got to tell you, it has been very hard. Not to get too deep into the weeds, but those first several months, really into the first year, I almost certainly had postpartum depression, postpartum anxiety, panic attacks. And ironically, I think being out of work made that worse because I had no escape from what was happening at home. And let me be clear, there was nothing happening at home. They're fine. They're healthy. They're normal, but the sleep deprivation and just the sheer stress and agony of trying to bring two life forms from, newbornness to something that, it was tough. Now it's easier. And I think the answer, the real answer to the question is, like, you have to prioritize. And that doesn't mean like on any given day, you have to decide, oh, I'm going to go home and be with my kids today. But it goes farther back to, like, what specialty am I going to choose? What type of practice am I going to join? Am I going to become a neurosurgeon and work 120 hours a week for 9 years during residency? Well, if you make that choice, you don't really get to make the other choices about seeing your family. Like, it just doesn't, there's just only so many hours in the day. So everybody has different priorities and different passions and different ambitions that drive them. And of course, you won't be happy if you don't follow those. But making choices to balance your work and family life go back, to the very beginning of the choices that you make about your specialty and your practice. And then within that context, particularly as an academic, you have to start saying no to things, because there will be no shortage of things that people want you to do. And the reason that you're taking the pay cut to be in academics is because you also want to do those things. You want to join this work group on diversity, equality, and inclusiveness. You want to write that book chapter with your buddies. You want to, help enroll subjects so that you can publish a paper. But those things aren't free. Nobody's giving you more time to do those things. So you're doing them because you're passionate about them, but there's no free lunch. Those things are going to take you away from home. So eventually you have to decide what's the most important to you and start saying no to other stuff.
I feel like there's a good lesson in there, much like earlier about having friends that buy you pizza and beer.
That's right.
You need that, and you also need the ability to say no to be successful in life.
Exactly. Well, and people will say things like, well, once you have kids, like, yes, it's harder and it's more work, but paradoxically, it's easier because now you become so focused on what's important that you can blah, blah, blah. I haven't gotten there yet. Like, I've definitely gotten to the point where saying yes to everything is not as important for my ego, for like how I feel about myself as a doctor and as a professor in this profession. I'm not all the way there yet, but I'm getting there. And my kids now are to the point where they're sort of fun, and so I want to go home, and I don't want to sit here and fill out more paperwork or whatever. So I think it is definitely evolving and moving towards saying no to just about everything.
Okay, awesome. So, at what age do children start being fun specifically?
For me, and a lot of people disagree with this, for me, it was the toddler stage when they started walking around and getting into stuff. Because I just found that was so much more engaging and so much less stressful than, the infant phase where they, cry all night or scream for no reason, or you can't like even put them down for 5 minutes to go to the bathroom. I mean, it's that. So for me, like when everybody else is like, oh, toddlers are terrible, I'm like, oh, no. This is where I shine. I'll come right in there. I'm on it. I'm on it.
Awesome. Thank you. Well, Dr. Choukalas, did I say it right that time?
Perfect.
Okay. That's, again, I apologize for messing that up after having like 5 walkthroughs. It's been one of those last 2.5 years, I guess you could say. Hey, thank you for taking the time out of your day to engage with us. Sincerely appreciate it. One last question that I didn't include on the docket, but what advice do you have for anybody looking to go into medicine or anesthesiology?
Good question. I would say be sure you want to do it because it's hard and expensive, and the financial and professional rewards for doing so that have been traditionally kind of automatic are not as automatic as they used to be. I love what I do and I'm paid well and yada, 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 but it's true what they say, that it's not like it was in the old days. And if you're going to borrow 400 grand to do it, like, you're going to be paying that off your whole life, and it will definitely impact your life to have that kind of loan burden. But if you get past that hurdle and decide you still want to do it, my advice is to be open about the things that you might actually like in terms of specialty. And I say that because everybody in medical school, from your classmates who don't know anything about the specialties to the professors that you work under, everybody's got an opinion about what specialty you should choose. And you want to know the secret to life? I'll tell it right now.
I need this.
Figure out what makes you happy, be honest with yourself about it, and do it. Sounds easy. It ain't easy. But if you can find that specialty that you actually like, no matter what that they're telling you, oh, this isn't, badass enough, or that's not a real clinician. You're not a real clinician. If it's what you like, you can be honest with yourself about it, do it. If everybody in your residency program is like, oh, I'm going to do a fellowship and I'm going to go and work at Duke or this big academic center, these hard cases, blah, 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 and you want to go work, 7 to 3 at a surgery center because it means you're off in the afternoon, and you're doing simple cases on healthy people, and that's what makes you happy, man, tell that classmate to shove it. Figure out what makes you happy, be honest with yourself about it, and do it.
Okay, perfect. Thank you. Again, Dr. Choukalas, appreciate your time. Thank you for joining us.
Thanks, Kyle. It was a lot of fun.
Thank you. Thank you to everybody for tuning in.
Bye, guys.